Let's take a look at what's in the influenza vaccine. In this table, I am showing you the 4 different strains that have been in the influenza vaccine in the last 4 seasons, starting from 2020-21. And you will see that there are 4 strains, so strain 1, 2, 3, and 4. 2 of them are essentially influenza A, and the other 2 are influenza B, so one for Victoria lineage and one for Yamagata lineage. And this is why the vaccines are called quadrivalent vaccines, because there are 4 different strains in it. And the 2020-21 season was the last time that we had a trivalent vaccine on the market. So trivalent will have strain 1, 2, and 3, whereas quadrivalent will add a 4th strain. Since 2021, every influenza vaccine on the market is quadrivalent, so we no longer have trivalent on the market. All of them have all these 4 strains. And what happens from season to season is that some of these strains may get updated. So for example, for the 2023-24, the strain 1 is getting updated. So now for the egg-based, it is influenza A Victoria sequence 4897 from 2022. That's H1N1. That's different than what was last year. And the rest of them are similar, or I should say identical to what was in the vaccine from previous year. So, the Yamagata actually has not changed in many years, simply because there is no variation in Yamagata in the influenza that's been observed. For Victoria, last year it was updated, so this year we will continue the same thing that was in the vaccines last year with strain 2, which is a H3N2 like strain. It is not changed from last year. We have not seen deviation. And and the other thing that I want to mention is that there is a difference between what's in the egg-based vaccines compared to the cell cultured or recombinant vaccines. So there is some minor differences, but for the most part, as far as what's in the vaccine, they're not really considered clinically different. CDC recommends routine annual seasonal influenza immunization for all persons aged 6 months or older who do not have contraindications. Now, there are no preferential recommendations for one influenza vaccine product over another, except specifically for adults aged 65 years or older, which we will cover on a later slide. Now, in general, it takes about 2 weeks on average for the body to fully respond to the vaccines and mount antibodies, so keep that in mind. And vaccination should be offered during September and October and continue through flu season while unexpired vaccine supplies last. And for non-pregnant adults, early vaccination, for example, when the vaccine becomes available in July and August, should be avoided unless there is concern that the later vaccination might not be possible. So if somebody's in their 3rd trimester in July, for example, they may go ahead and receive the vaccine. We'll talk more about vaccination during pregnancy on a later slide. And of course, COVID-19 vaccines can be co-administered with influenza vaccines. It's been shown both safe and effective. Now, here's a summary of the available products for this influenza vaccine season. We have one that's a live attenuated influenza vaccine, so the flu mist. Historically, the live attenuated vaccine has performed poorly compared to the inactivated vaccine. So for that reason, it is only recommended for persons aged 2 years through 49, because anybody under the age of 2 or age 50 and older is at risk of complications from influenza infection. So therefore, for those people, we want the better vaccine, so the better more effective vaccines that are pretty much everything else in this table. Next, we have inactivated influenza vaccines. Now, traditionally, we have the standard dose. So this is 15 microgram shots. And we have several different formulations from different manufacturers available. Now, these are all IM injections, whereas the flu mist, the live attenuated, that's actually a nasal spray. So it's actually helpful for people who are afraid of needles. For these inactivated influenza vaccines, these are essentially all of them are quadrivalent. So when you see a number, the number 4 means that these are quadrivalent. As I mentioned earlier, we only have quadrivalent available on the market nowadays. Next, we have cell cultured. So the previous vaccine that I mentioned, they're all developed in eggs. So, essentially chicken eggs are what's used to grow these vaccines. For the non-egg based, we have the cell culture. So cell culture essentially uses mammalian cells to grow as opposed to the egg cells. We have one product, Flucelvax, so it's kind of in the name cell. So it's cell cultures, Flucelvax. And it's also quadrivalent. Pretty much these are for age 6 months and older. We also have recombinant influenza vaccine. So this actually uses recombinant biotechnology to make these in a lab. These are essentially developed in some bugs inside the lab, and FluBlock is the formulation that's available. However, keep in mind that this is only approved for age 18 years and older, so they may not be used in children. And then specifically for elderly who typically respond less to the vaccines, we have a few formulations that boost the response. So one is adjuvanted inactivated influenza vaccine. So this uses adjuvants to increase immunogenicity. So FluAd. So ad is in the name, adjuvant, and this is for age 65 and older. And we also have the traditional inactivated influenza vaccine in higher dose. So HD is for higher dose. So instead of the 15 microgram, this would be essentially 60 microgram. So that's a higher dose. Now I will mention that the recombinant influenza vaccine also has a higher dose compared to the inactivated influenza. So instead of the 15, it uses 45 microgram, but it's still less than the high dose, which is 60 microgram. Now I mentioned these because these will be essentially these three at the bottom will have higher efficacy in elderly. So essentially everything is made through eggs except recombinant and cell culture, which brings us to the question, what if the patient has egg allergy, because some of these egg proteins might be in the vaccine. Although not common, you may come across patients who have egg allergy. As I mentioned, majority of the influenza vaccine formulations are grown in eggs. Both cell culture grown and recombinant influenza vaccines are considered egg-free. The recombinant vaccine utilizes recombinant DNA technology to manufacture the vaccine, and the cell culture grown vaccine utilizes mammalian cells instead of eggs. So should we only give recombinant influenza vaccine to patients with egg allergy? Well, first, it's important to know that CDC recommends considering patient observation for 15 minutes after administration of any vaccine, not just the flu shot, and regardless of whether they have had allergies or not. Secondly, regardless of reaction to egg exposure, even if anaphylaxis, the recommendation is that all persons aged 6 months or older with egg allergy who do not have contraindications should receive any licensed and recommended influenza vaccine, including the egg-based vaccine. The bottom line is that egg allergy is not a contraindication to receiving egg-based influenza vaccine. Now, what if the patient had allergy to a previous influenza vaccine ingredients and not just egg allergy? We can consider 3 different groups. So one would be people with an allergy to egg-based vaccine. The second group would be people with allergy to cell-cultured vaccine. And last would be people with history of reaction to a recombinant vaccine. So in general, when the CDC says precaution when it comes to allergies, use should occur in an inpatient or outpatient medical setting under supervision of a provider who can recognize and manage a severe allergic reaction. And of course, vaccine components can be found in a package insert. So for the first group, those who have allergy to egg-based influenza vaccines, any egg-based vaccine, it's contraindicated for these patients. However, they may receive a non-egg-based vaccine, so either a cell-cultured and recombinant. Now, again, this has nothing to do with eggs. This has to do with allergy to an egg-based vaccine. Now, for the second group, who, if they had an allergy to a cell-cultured inactivated influenza vaccine, any egg-based is contraindicated as well as the cell culture vaccine. However, they may receive, cautiously a recombinant influenza vaccine. And of course, last group, if they had a history of allergy to recombinant, again, egg-based is contraindicated as well as recombinant influenza vaccine, but they may cautiously receive cell-cultured influenza vaccine. And of course, if it is unknown which influenza vaccine they had a reaction to, then an allergist can be consulted to figure out if it's okay for the patient to receive a vaccine. Now, what are vaccine considerations during pregnancy? So persons who are pregnant or postpartum should receive any inactivated influenza vaccine or recombinant influenza vaccine, as long as this is before or during the flu season, and can be given before pregnancy and during all trimesters of pregnancy, but in general, limited data during the first trimester. The live attenuated vaccine should not be used. It's actually contraindicated during pregnancy. And in general, there is less experience with more recently licensed inactivated influenza vaccines, such as all the quadrivalents that are available on the market, and the cell cultured based vaccine. And there is limited data with recombinant influenza vaccine. Now, for immunocompromised patients, the same recommendation is made. So either inactivated influenza vaccine or the recombinant, and of course, inactivated either egg-based or cell cultured, similar to pregnancy. And live attenuated should not be used. So the live attenuated, because they replicate in the body, they should not be used immunocompromised because it can replicate, and get out of control due to immunocompromise. Last, what if the patient is taking influenza antiviral medications? Now, administration of inactivated or recombinant is not affected by antiviral agents. However, if somebody is to take the live attenuated because that vaccine needs to replicate in the body, antiviral medications will affect the vaccine efficacy. And when it comes to our antiviral agents used for the flu, the half-life makes a difference. So, some of these, such as pramivir and baloxavir, have much longer half-life, whereas oseltamivir and zanamivir have shorter half-life. So in general, the live attenuated influenza vaccine will have reduced effectiveness if oseltamivir is taken within 2 days before and up to 14 days after. So in other words, if somebody is taking oseltamivir for an actual infection or for either prophylaxis or whatever reason, and they are to receive a live attenuated, they should wait 2 days after discontinuing oseltamivir to start vaccination. And then once vaccination is given, they should wait at least 14 days before they can receive, for whatever indication, another dose of oseltamivir. And the same concept applies to pramivir and baloxavir, but the timing is different. So for pramivir, 5 days before and up to 14 days after. The 14 days is because it takes, on average 2 weeks for the vaccine to kick in. So once it's given, regardless of which one it is, you want to wait 14 days for the vaccine to replicate and mount a response. And then the other ones, the 2 days, 5 days, and 17 days, you essentially waiting for these drugs to be cleared from the body based on the half-life, and then give the vaccination. Now, what if the patient is elderly, and that's defined as age 65 years or older? So there are 3 preferential recommendations. So either the high dose inactivated influenza vaccine or the recombinant influenza vaccine, which essentially has a higher dose than the standard dose in activated influenza vaccine, or an adjuvanted inactivated influenza vaccine. And of course, they do say that if none of these are available in the pharmacy, then any other age-appropriate influenza vaccine should be used. So any vaccine is better than no vaccine. So you don't want, in other words, if somebody's at the pharmacy and these three are not available, you do not want to, order it and have the patient come back, because there is a good chance that they may not come back. So any opportunity to vaccinate individuals is very important, because any vaccination is better than no vaccination. And the reason these three are preferred over others is that, for one, the high dose was studied against the standard dose, and these are specifically in the trivalent vaccines where they did a randomized controlled trial. And they found that the high dose was superior to the standard dose. Specifically, it had about 24% greater relative efficacy compared to the standard dose. And when it comes to recombinant, compared to the standard dose, again, recombinant has slightly higher dose in it. So in elderly, they also saw higher efficacy, so about 30% greater relative efficacy compared to the standard dose. And of course, the adjuvanted Fluad uses MF59 as an adjuvant to increase immunogenicity, which showed about 63% greater relative efficacy. This concludes this presentation.